I think we have audio now. Thank you, everyone, for coming out so early in the morning. And thank you to both the panelists on the table that have made a commitment to the issue and have just landed off a plane and gotten here. So thank you. I think this will be a mobilizing discussion. We are discussing global health security, both the role of women and girls within the global health security and also infrastructure and issues, as you know, that we've been discussing both at the World Health Assembly and over the past few months. The way we do our panels is that we let each of our speakers introduce themselves so that we are able to have a more dynamic conversation. So with this, I'd like to get started, and I'd like to start with Ambassador Jenkins. In terms of the global health security agenda and the role of women and girls, how do you see that evolving over the next five years and 10 years, really?
Great, thank you. And sorry that I had to hold things up. I just landed from Washington. My flight, I was actually in Indianapolis yesterday, and the flight from there was late, so apologize. Thank you for inviting me, Joanne, to this event. The Global Security Agenda, which I'm assuming folks know a bit about it, which is a 5-year effort that has about 44 countries plus who are all working toward the goal of reducing infectious disease threats. And it was launched last year in February, and we had a very big event at the White House last year on September 26th, where 44 countries made over 100 commitments toward preventing infectious disease threats, looking at it from a prevent, detect, and respond angle. And there's a number of actions that all the countries are working on to actually achieve this goal, working together in the next 5 years to really bring together the health, security, development, law enforcement efforts in a multi-sectoral way to address these issues. And a very big part of that effort, of course, is working with those outside of government to include NGOs, industry, foundations, and private sector. So I'm very happy to be here at this event. And I can answer more questions about GHSA as we go forward. But as far as the particular topic, this was actually something that was raised at one of the meetings we had in Washington with our colleagues from Finland who is chairing the steering group for the GHSA this year. And they raised the issue of women and girls in global security agenda. And I have to say that I had not really thought enough about that. And when that issue was raised, we thought it would really be ideal to focus some attention on this particular issue, to look at the unique issues that women and girls face and how the GHSA can actually try to address some of those issues. So this is a new part of the effort. And I'm looking forward to hearing from the panelists, but also from those of you in the audience who may have some perspectives on and some thoughts on how the area of global health currently is a challenge for women and girls, and how this agenda, where you have a global effort to try to address infectious disease threats, can really focus on that. So my hope is that this is starting something that can be a part of GHSA as we go forward, and that we can have an actual aspect of GHSA that looks at women and girls. So,
thank you so much. With that, I'd like to turn it over to Kent to really give his perspective in terms of both his experiences on the ground and why, from a very personal viewpoint, the global health security is so important for us to not only get right, but to implement quickly in some of these countries.
Thank you.
And sorry, please introduce yourselves to the live stream audience. Thanks.
Thank you very much, Joanna. It's an honor to be a part of this panel with these distinguished panelists. I feel a little out of place. My name is Dr. Kent Brantley. I'm a family physician from the United States. And my my experience and perspective on global health security and its importance comes from my experience in the country of Liberia, where I moved with my family prior to Ebola in October of 2013. And I was working there at a small hospital under a program that's operated by Samaritan's Purse, a small faith-based organization out of North Carolina that does a lot of international disaster relief, but also a lot of development work. I moved with my family to Liberia in October of 2013 to live and work there, not as disaster response, but simply trying to help build up the healthcare system in that country. And when we at our small 50-bed hospital learned about the Ebola outbreak at the end of March in our neighboring country of Guinea, we immediately began preparing our facility and our staff, because we knew that if a patient with Ebola showed up at our facility and we were not prepared, it would cost the lives of some of our colleagues and hospital staff. So we began searching for whatever kind of preparation we could find. No one in our facility had ever dealt with Ebola before, because no one in West Africa had ever dealt with Ebola before. But we found a manual online that was published by WHO and CDC in 1998 entitled Infection Control for Viral Hemorrhagic Fevers in the African Healthcare Setting. And we printed off that manual. One of our doctors, a general surgeon from the state of Oregon, Dr. Debbie Eisenhut, printed off that 180-something page document, put it in a binder, a 3-ring binder, and that became our guidance manual as she created a curriculum for our entire hospital staff. And we put every hospital staff member, from the doctors and nurses to the cashiers to the janitors, through a 2 to 3 hour hands-on curriculum covering everything from what is Ebola and how is it spread, to how do you mix a chlorine solution, to how do you decontaminate a dead body. And we practiced putting on PPE. It was a very hands-on experience because we wanted everyone in our team to understand the importance of the preparation we were going through. One of the problems, though, was that we didn't have PPE at that time. So what we practiced putting on and taking off were surgical gowns and latex gloves and surgical masks, and we had kitchen aprons that we put over our surgical gowns, and we had bandanas that we tied over our heads and around our necks to cover all of our skin, because that's what we had at the time. And we began partnering. My hospital is called ELWA, E-L-W-A. You may have heard of it in the news because it became one of the major treatment centers in Monrovia. It's run by a small mission agency called SIM. The organization I worked for, Samaritan's Purse, has offices on that same campus as the hospital, but they're independent organizations. But we immediately began partnering together to prepare our facility. And Samaritan's Purse began providing equipment and supplies and logistics, and so they began providing us with our initial PPE, the Tyvek suits and rubber boots and rubber aprons and all of the appropriate equipment. We also had to prepare our facility because our 50-bed hospital was like most hospitals in our area, that we did not really have a good setup for isolating a patient. In a place where tuberculosis is endemic, we did not have good isolation capabilities, as did neither did most of the hospitals around us. So we took our small chapel where we had our daily staff devotionals, and we converted it into a 5-bed isolation unit. And we maintained that unit for months, from the beginning of April through the increase of the outbreak in June and July. It's important to, as we discuss the role of healthcare systems and how fragile some healthcare systems in countries like those affected by Ebola were, I want to talk about the two waves of Ebola that came to Liberia. The first wave at the end of March, beginning of April, there was an epicenter in the northern part of the country in Foya, and a few cases around the Monrovia area. But we never saw any patients in our facility, and that initial wave had 27 cases in the whole country, and they were contained, and Liberia went for more than the month of May, with no new cases. And I think we all kind of breathed a collective sigh of relief and thought that we had dodged the bullet on Ebola as it was continuing to get worse in Guinea and Sierra Leone. But in June, when the second wave occurred, on June 11th, we received a phone call from the Ministry of Health saying that they wanted to bring 2 suspected Ebola patients to our facility, because as it turned out, we had the only functional isolation unit in all of Montserrado County, in all of Monrovia. Even the government hospital that had been prepared in that first wave and had put together a good isolation unit, it was no longer set up with a staff ready to work in it. So our little 5-bed unit, which we never intended to be a treatment unit, we intended it to be a holding unit where we could keep patients for a few days as we got their tests and kept them safe and protected the rest of our hospital. We became the treatment unit in the earliest weeks of the second wave. And it required collaboration from lots of entities. We were well supported by the Ministry of Health as they provided PPE, and after the first couple of weeks, they were able to even provide some personnel, a couple of physician's assistants and some nurses. We had some visitors, some consultants from MSF who helped provide some training during the first wave. They came and spent 2 days with us and gave us 2 half-days of training in addition to the curriculum we had put together for our staff. And they provided us with an updated manual. And Samaritan's Purse and SIM, ELWA, all of those organizations had to partner together to make a response possible. So we received our first patient on June 11th, and it wasn't until early July or late June that there was another isolation unit really functional at JFK Medical Center. The outbreak continued to grow, and we were seeing patients in our facility. JFK was seeing patients in their facility, and the Ministry of Health recognized the need to consolidate our efforts so that our material resources, our human resources, our knowledge would not be split between 2 facilities. And it required that collaboration and cooperation between all of these entities, all these organizations, to make that happen. And Samaritan's Purse stepped forward and offered to the Ministry of Health to take over the management of clinical care in Monrovia on behalf of the Ministry of Health, just as they had done weeks earlier in Foya, in the northern epicenter. And so this small faith-based organization partnered together with the government of Liberia and consultants from MSF to set up this consolidated unit, which we built in a building in our new hospital construction project. We converted it into a 20-bed ETU. And we became the team treating Ebola patients in Monrovia in those early weeks and months of the outbreak as things were getting worse in July and August. It required volunteers and workers from the Ministry of Health helping staff our unit, but it also required great effort from our little hospital where we were pulling nurses off shift, every shift, from the wards and the emergency room to staff the ETU. And it created an incredible strain on our hospital as other hospitals were having to close their doors because there were cases occurring and their facilities would be contaminated, and they would have healthcare workers who contracted Ebola, and they would have people not coming to work out of fear of catching the disease. And so as we watched our sister organizations, our sister hospitals around us having to close their doors for good reasons, we were trying our best to maintain some sort of basic healthcare services to our community, while at the same time putting most of our efforts and resources into running the ETU. And the question was on the table of, is global health security the responsibility of national governments and international organizations, or does it require something beyond that? And I think the answer is that yes, it absolutely is the responsibility of national governments to take responsibility for their own country's global health security, their health security. But we have to recognize and acknowledge and utilize the many players that are on the ground in these countries already there providing basic services. And it requires the national governments to coordinate those efforts and to know who those players are and draw them into the bigger plan of how to create a resilient healthcare system. We can't do it without those organizations that are on the ground there, whether they're NGOs or faith-based organizations or private institutions. They need to be coordinated in a cohesive effort to create a system that is resilient and can absorb these shocks, but also provide a stable, basic healthcare system on an ongoing basis. So I wanted to share some of my story to help put a face on the reality of these weak systems and how easily they get stretched, and the real players who are on the front lines taking care of patients and bearing the weight of these crises.
Thank you for those remarks. Is this on? Okay, can you hear me? Great. Thank you for those remarks, and I'd like to turn over now to Ambassador Lehtinen from Finland, the Special Envoy for Ebola, who I know has done a lot of work in the field and was there for a lot of what was going on during Ebola, and we welcome you and look forward to some of your thoughts on the issue of women and girls.
Okay. Hello, good morning, everybody. My name is Tiina Jortikka-Laitinen, and I come from the Foreign Minister of Finland, where I've been working as a special envoy on Ebola since last fall. And I would just like to start by thanking the organizer for inviting me to this very, very important and topical discussion. I've been following a number of discussions here in Geneva the last few days, and none of them has been focusing on this particular issue, so I congratulate you for taking up this very, very important topic. And I also want to say that my government is a keen supporter of the global health security agenda, which we are chairing this year. And I think this is an initiative that can add value and really to bring things forward. And gender equality is a topical priority of my government, and that is where these security and health security and gender issues meet in a very, very good and positive manner. Another priority to my government is to support NGOs, and this is where my contact point to these three Ebola-affected countries are. I have been traveling in the region with Finnish NGOs that have been actually actively engaged in various activities, especially in Liberia and Sierra Leone. And earlier this year, I have had a chance to visit 2 times Liberia and Sierra Leone, and met with various members of governments, international community, and local civil society. And during those visits, I have also had many discussions with representatives of gender-focused organizations and women activists, many women survivors of Ebola, and women health and burial workers. So this has given me a special perspective and given me valuable first-hand source information. And many of the findings, of my own findings, go along with a recent field research study on the gendered impacts of Ebola in Liberia, undertaken by a Finnish NGO, Finn Church Aid. And this study is now also available online. I have a copy of it here, but it is really a very, very small study, but still gives faces to statistics and the figures, and I think it is an important contribution. And this study shows, and I think we all know it now, that Ebola outbreak has affected genders differently. And I think it was unfortunate that the official epidemiological data disaggregated by sex was available only at a later stage of the Ebola outbreak, and this has made some difficulties and to clearly to understand what the actual situation has been and is vis-à-vis gender disparities amongst reported cases. But however, irrespective of the actual figures, historical evidence demonstrates the vulnerability of women and girls in this kind of crisis situation. But unfortunately, yet there is very often an obvious lack of gendered responses to disasters. But also, I think it is not only about statistics. We know that even though women suffer in many ways in conflicts and other disasters, they rarely form the thinking behind the responses. And this is something that came up out during the study also, that even though their value as peacemakers, caregivers and generation bearers is known to all of us, but it is not fully recognized or appreciated enough. And we also know that there is a lot of documentation available on the lived realities and responses of women in conflict and disaster situations, but yet we still fail to focus on women as valuable agents of change and social mobilizers, with a central role to play in shaping a comprehensive and multifaceted response system. And I think the Ebola crisis has shown once again how short organizational memories can be. The information on how to plan gender-sensitive responses to infectious diseases is widely available, but even WHO failed to follow its own recommendations on the matter at the beginning of the epidemic. Therefore, I think, and that is one of my own conclusions, and it comes out from this study as well, that it is really important that our future responses and strategies are gender sensitive, and we don't forget it, because we know that we have to do it, but we seem to forget that lesson we have already learned. And I think it is now high time to really to learn that lessons from the current epidemic should be drafted and made available for the next time. And they should be available in each involved organization, so that we are all following the same lessons learned and implementing them when the next Ebola comes. I think it was very, very importantly highlighted already that there is a very important dimension, community engagement dimension in and we must work to empower and mobilize prominent members of the community, also those who recovered from the disease, and organizations working at the grassroots level, really to disseminate clear and accurate information about EVD transmission and prevention, while promoting stigma reduction in the process. And I think one of the conclusions or recommendations that come out is that when planning and implementing gender-sensitive program, a close relationship with community leaders should be established. These leaders, they are often well-respected and trusted individuals, and they can, in many ways, enhance not only the work in the communities themselves, but also the sustainability of the project at hand. I think we must, when we start to focus our attention to the recovery phase, I think we have to concentrate on maintaining and utilizing the already established community relations. Since societal stigma of the victims and their families is deep, and social cohesion in the country has been in many ways damaged in the crisis, programs that aim to enhance mental well-being and community cohesion are crucial for successful recovery. I think this goes without saying, but I think that in addition, highly affected groups such as urban petty traders, prostitutes, and bushmeat hunters should be supported by providing education or alternative income generation activities. And one experience that seems to work and where I think there is a lot of potential is and there are a number of initiatives, but one initiative relates to women's livelihoods, and as we know that a number of international forums have noted already that one of the most important means to recovery is to improve women's possibilities of earning their living, and improving their position is in direct correlation to the poverty of the whole family, and even to that of the entire local community. And this fact was actually also recognized by the founder members of sort of a new and innovative initiative at that time. That was 2007, when the Women's Bank was founded by Finn Church Aid, a Finnish NGO, and a group of influential Finnish women. And now the bank works in several countries, and it provides funds and small grants for projects that promote women's economic livelihood, skills and legal rights, give small loans and vocational training, and tries to promote in many ways women's entrepreneurship. in Liberia, I had the chance to talk with some of the women survivors of Ebola and women in mothers and healthcare workers in small communities, and especially in those communities where they had been able to access to this small grants program, they seem to be extremely happy about this possibility, because now in the situation, and especially when the attention is now turning away from their situation, there seem to be a sort of an emptiness and somehow feeling of being left alone. And they said that the first thing is to find something that could support their families, even a small-scale thing, but something that could give them a new start. So I think, I would like to finish by saying that we know that there are many lessons learned processes underway, and I think and we must learn, and I think we will learn to do it better next time. But as I mentioned already, none of them is focusing especially on gender issues. And but I just want to underline that women must be included in strategizing when assessing the scope of the outbreak, and designing responses and implementing interventions, and somehow we have to capitalize on this expertise and knowledge we are now getting from West Africa. Thank you very much.
Thank you for those remarks and reminding us that we really do need to keep the idea and the concepts of gender in the forefront of whatever we do. And the fact that, as you mentioned, that this is the first time this issue came up during this week while you're here, reflects the fact that we really need to keep that in mind. So thank you for that. In the time left, we're going to hear from our final panelist. And then I believe we have some short comments from some of you in the audience who will be talking from the perspective of civil society, implementers and chemonics, and also hopefully someone from the private sector will volunteer to say a few words. So first I'd like to turn it over now to Dr. Tulu, Special Envoy to the Southern African Development Community, or SADC as we know it, Health Ministers and African Regional Head at USAID. You have the floor.
Yeah, thank you very much. Actually, I am the UN AIDS, not USAID, regional director.
Okay.
Yeah, regional director of UN AIDS for Eastern and Southern Africa, and former Minister of Health of Botswana. So I'm glad I'm coming then before civil society and the private sector, because I think that's where in my talk I'll try to be able to merge them, because I belong to those worlds. I was born and bred in civil society, became a politician, an academic, and now, of course, an international civil servant, but still in the AIDS response. And my thing is, I think we have a lot for whatever threat to global health security. The response to AIDS, the global response to HIV and AIDS, really has a lot of lessons to give. Firstly, my belief is that for any threat to really be solved, it needs champions at community level. It was the rallying cry of people living with HIV, nothing for us without us, that made the governments stand up and try to really see what to do about our HIV and AIDS. It was also that very rallying cry, too, of civil society suing their governments and making sure that governments negotiate with the private sector about the prices of drugs. That what made it possible for countries, especially in my region, to be able to then roll out ARVs. But most important, it was actually also that rallying cry that made countries focus on who to prioritize when it came to ARVs. And indeed, for a country such as mine, well, let me also say that it was also civil society that made sure that the countries can know and actually venture into trying to give ARVs, because the international community During the time of the epidemic when it started, and there was treatment, the international community was saying, for Africa, it may not be possible because they can't even tell the time. This thing needs to be taken at such and such. But it was civil society that said, we need it. It's got to be done. And indeed, when I became minister, it was really actually to prove to the world that, yes, it is possible for ARVs to be given even in a resource-limited setting. So Botswana was the first country to give ARVs in 2001. But mother-to-child transmission, because we knew we wanted to save the lives of our women and children, we started it in 1998. And President Muhai simply decided we'll have to put our own budget. But however, the rallying cry was also the fact that with that kind of success, we're able to have the international community come in and really say, well, here's a country that is trying, let's assist. And of course, the rest is history. Countries are now rallying. We're doing well in the AIDS response, but my fear as a regional director is that there is now complacency. We are having significant success. For example, one of the targets was that by 2015, we will actually be at the point of eliminating new infections among children and ensuring that their mothers are kept alive. And that particular target, yes, by end of 2015, we will have met it. Putting 15 million people on ARVs, we will have met that. However, these were targets that were meant just to show progress. But what I'm seeing with the governments is that there is a complacency. People are no longer dying. So there is now a move towards something else, climate change. And if you look at the Sustainable Development Goals, HIV and its twin brother, and they are brothers, not sisters, tuberculosis, have been now, given like a line, eliminating malaria, tuberculosis, and that's it. So that's where I think the problem is going to be, because the people who are left behind in the AIDS response are already elaborated in the UNAIDS report. Women living with HIV, adolescents, among whom the epidemic is going up, and among whom deaths due to HIV actually accounted for more than 60% last year in the whole globe. So, and men who have sex with men, we have quite a lot of populations that are still left behind in order for us to be able to really eliminate the AIDS response as a threat, as a public health threat. So what has happened is simply that some governments are aware that we need to do something. And therefore, at SADC level, the ministers of health of SADC have been able to form a partnership with the SADC private sector constituency, which was former global health, global business health constituency, but now is SADC global, SADC private sector constituency. But I'm hoping that even though I'm saying SADC private sector constituency, once you get to learn what it's all about, I'm hoping that we have more and more partners, because the idea is simply to say, well, no government can do it alone. We want to partner with the SADC private sector in such a way that we can actually even have a SADC trust fund, because we don't know how long the global fund will last. But if we have a trust fund where everybody can be able to put in not just funding, but even the efficiencies of scale, for example, supply chain management, training of health professionals, those things can be done as a community. We're hoping that and is facilitated by GHD. So it's really something that we think would ensure that, therefore, we will be able to end, well, it won't be just HIV now, but every other, public health threat that would come about. Yeah. So I think I'll stop there. Yeah.
Excellent. Thank you very much for those comments. I'd like to now have our volunteers who are going to say a few words on civil society and implementers. Do you have I guess I have to come up
Need
here.
a mic?
Yeah.
Need a mic.
I have a loud voice. Oh, there you go.
And just to explain to our live stream audience, we usually would do a little discussion. Our discussion leader would lead it, but due to timing, we're going to go to remarks. Thanks.
Okay, great. Thank you very much. I'm Christine So. I'm the Executive Director of the Global Health Council, and I'm so pleased to be part of this panel. I'm pleased to have already spoken and conferred with a number of our panelists and people in the room already about this topic. I really appreciate the comments that have been made this morning, and I think we've had such a nice broad perspective, both from leadership in GHSA, speaking about what the reality on the ground looks like, thinking about historical perspectives, and I'm so pleased that we've had so many mentions in the last few remarks around women and girls, around the need for champions, and also the thought of marginalized populations and hard-to-reach populations and how they may be affected by global health security issues. I may be working backwards here because I was taken by these last remarks and the idea of complacency. And I think that the global health security agenda is something that we saw come really back up to visibility last year. And the whole Ebola crisis really brought it home to us how important it is. But in the global health community, and certainly in civil society, we've been very concerned about complacency coming back, both in the context of the Ebola crisis itself and also in the context of the larger global health security agenda, both as a thing but also as an issue. And civil society is a critical part of this, and I think we were able to see this through the Ebola crisis. We have talked a lot about the failure of health systems and the fact that we need resilient health systems. I would argue that we need resilient health ecosystems, which includes community. And community systems are not necessarily part of the health system. Sometimes they get lumped in together, but in fact, community systems exist outside of the health system, but hopefully in an appropriate situation work in tandem with the health system. But as we saw with Ebola, without community leadership, without appropriate messaging, without appropriate community mobilization strategies, without reaching out to people within communities who are going to be the hardest hit, both in terms of the disease itself, but also in terms of the socioeconomic impact and other factors such as marginalization after coming back from the disease, we absolutely have to be involving communities. And if we're going to reach women and girls in particular, those communities are critical, as are the community-based organizations that work with women and girls and that are run by women, and we need to remember them in the response. I will say a point of concern around the involvement of civil society in the global security agenda, global health security agenda as it has been rolling out, has been that while we are very pleased to see the government leadership on the agenda and see it taken up by so many countries, there is a concern about how civil society and other non-state actors are brought into these discussions and brought into the actualization of the agenda at the country level. And a question, I think, back to our panelists would be, how are countries being encouraged or even, strongly encouraged to include civil society groups, to include private sector, to include non-state actors in their thinking around what global health security means in their country, in their thinking around what global health security means for each of the different themes, and how that actually gets put into action. So, we've worked with Ambassador Jenkins and hope to continue doing that, really from this perspective of bringing in other stakeholders to the agenda. And I think that that's something that we'd like to continue to explore because we know, and now we have proof from the Ebola crisis, how important all these different stakeholders are in actually making this effective and having an impact. Thank you.
Excellent. Next, we have our next speaker, our volunteer speaker.
Should I volunteer something? If we can have a speaker from the private sector, to get a private sector
Perspective would
perspective.
be nice.
Oh, come on.
Don't be shy.
Kate. Kate. All the
private sector prepares their remarks. I want to address two issues. That one is that of gender, then the other is that of resilient health systems. And in gender, I think it is very important to look at the women and girls. They are the first carers in the families, and they're the ones who are at most risk of getting infectious diseases because they're having the most frequent contact with sick family members, and often it's their responsibility alone. And so I think that we have to get men and boys more involved in caring for their family members, so that it's a shared responsibility, but also making sure that everyone in the family knows how to protect themselves in times of epidemics. So really getting a lot of equality there. Also, I think as we look at the health system and gender, most health systems are highly gendered, that the vast majority of health workers are indeed women, but they often tend to be in the lower level positions. So it's very important that we create leadership opportunities for them so that they are able to go past that gauze ceiling and really get into the leadership positions, because even if a workforce is highly feminized, if the people making the decisions don't have a gender perspective and aren't thinking about the needs of women, the needs of girls, the health system won't be responding as well to all the members of society. And then on the issue of resilient health systems, I was very struck by what Dr. Brantley said, that they had their isolation clinic when the public sector had already closed them down. I think that what makes resilient systems is the diversity that you have, the diversity of approaches, the diversity of resources, the diversity of relationships and networks, the diversity of funding. And so what you saw in Liberia, you saw a government which at one point became overwhelmed, but luckily there was a FBO sector, faith-based sector. There was an international NGO sector in the form of MSF. There were also for-profit sectors. MSH did a lot of work with drug sellers to make sure that they were involved in a positive way as possible during the Ebola epidemic. So I think it's this diversity of approaches that really adds to the resilience.
Excellent, thank you. Excellent. I see some hands up now. Yes, with the in the back with the red glasses.
Great glasses.
Thank you. My name is Chippa Mutobi. I'm head of sustainability strategy at Discovery. I'm here with my colleague Brett Trump, who's actually the CFO. So it's an interesting space, I think, for us being able to participate in the conversation. I think interestingly, listening to the speakers, I should also say I also provide support to Professor Tlo, who is my former minister, because I'm actually originally a Botswana citizen. But I think the aspect that she's raised, which is what I'd really like to speak about, and I'm sure Brett can speak more on Discovery's engagements, but as a private sector, the diversity of engaging is what's so critical. I think in the Southern African region, and I think just to give some perspective, setting up a private sector engagement in terms of being able to look at diversity of, and I think the previous speaker said it really well, diversity of resourcing, diversity of efficiencies, what was quite critical, because I think a lot of times the trust between private and public sector can be challenging. And I'm putting it as delicately as I can, because Madam Sheila is the best diplomat that I have, so I kind of take a leaf from there. But it's always a challenge. And when you start looking, and I think Ebola just forced us to have to engage on it. I mean, we saw how the Southern African ministers rallied quite quickly. But as private sector, we needed to be at the table. And I think civil society becomes such a critical, painful engagement sometimes, because then there is this extra wall between us being private sector and civil society. So in the SADC private sector constituency, what we've done is try to really mobilize and work really closely together, but realizing that as the private sector, we've got to have all the critical players at the table. So the constituency is not just also around Southern African engagement, but it's really looking at global players that have multiple platforms. So I thought I thought it was really interesting listening to the speakers, but I think what's key for us as well is that community engagement. And we really, I think, as the private sector constituency, would like to be able to share the elements that we're seeing that are really, really helping us be progressive in the region. Thank you.
Thank you. I know it's 8:30 and we're supposed to end, so maybe if people could make really quick comments, that would be great. So I have one here. one there, and so those four, if you can make quick comments, and then Joanne has a few concluding remarks.
Thank you very much. I'm Laura Hemeke, also from IntraHealth International. Thank you again, everyone. I agree with the comments that have been made. I think what we haven't talked about is women and girls and children as recipients of routine health care, and what happens when something like Ebola destroys the routine delivery of services. I read recently that due to Ebola, 120,000 women died during pregnancy or childbirth because they were not able to access care. So how do we, and especially from maybe to hear from Dr. Brantley about what was happening in Liberia when routine health services went away. 800 women around the world still die every day around pregnancy and childbirth. So how many have died in the past hour since we started this discussion? And what can we do as a global community to ensure that vaccination services, family planning services, safe delivery services are continued to be provided in the face of emergencies? And there are emergencies, they're growing, they're not shrinking, the number of public health emergencies around the world. Thank you.
Thank you for that perspective. I think we have our next speaker
Right in front.
in the front here.
And sorry, I do ask you to keep comments short, just because the next panel, one of our speakers needs to leave by 9:30 to the airport.
My name is Lola Dari. I work in Nigeria, and I just want to make one point about resilient health system. The system that's not functional cannot be resilient. And I think we need to first, and at this time, also focus on how to make these systems functional during peace times and during times of non-crisis. Many of our systems are dysfunctional at this, whether it's routine or in crisis. Two, health systems need to take advantage of the investments we've made during the siloed programs in polio, for UNA, from HIV, for malaria. There are many microsystems working at country level that we need to take advantage of. The capacity of Nigeria to contain Ebola was based on using the infrastructure for polio. And we're not looking at how we can yield the benefits of the various investments to build a comprehensive national health system that is able to respond to shock. So I think a system that's not resilient cannot and will not be, that's not functional, cannot be resilient. But if we take that forward into the next 10 years, there are many things we can learn, and we have learned from the MDG that can help us to strengthen partnerships that deliver services and make health systems resilient. And without wanting to describe them in detail, I think we need to begin to look forward into the next 10 years into financing. How will financing drive our capacity to coordinate, strengthen, and make our health systems resilient? We're going to be looking at multi-sectorality. Ebola has also brought to us that we're not going to do it alone in the health sector. We're going to have to work with other sectors to make sure that we can deliver services. What is multi-sectorality going to mean? And the last bit of it is the partnerships that we need. It's going to be not a magic bullet. The health sector is going to learn something different and how to work in partnerships that deliver on a particular crop. And so for the first time in health, we're not going to have a product to monitor. We're going to have to monitor process, we're going to have to monitor behavior, and that's what matters in partnership. Thank you.
Yes, our last two, please. What did you say?
Thank you. I'll try to be very brief. My name is Aaron Emmel from the American Academy of Pediatrics. On the women and girls piece, I just want to focus a little bit on the girls, because girls, obviously the gender component is very important to make sure that they are protagonists and partners in development, but I also want to address the special needs of children, particularly in disaster settings. Children have special needs, whether it comes to the continuation of school and education or the effects of toxic stress on early brain development. And so, as some of the other people in this room have already said, one of the ways to ensure that there is preparedness and response for disasters is to make sure that there are routine systems functioning, and the groundwork for those have been laid by routine immunization systems, by having a strong health worker sector. But the private sector also has a very important role to play in all of this, when we look at the lessons that the United States government has learned about population security for its own people, a lot of those lessons have come from partnerships with the private sector to try to reach the needs of women and children in other countries, whether those are point-of-care diagnostics, water purification systems, or vaccine stabilization, to give 3 random examples. Those are all lessons which have been learned with the private sector, which now have been applied by by BARDA under HHS, by DTRA under the Department of Defense, to learn how to deal with refugees and other populations. And so this is a partnership which we want to make sure integrates the needs of children.
Thank you. And if you could be extremely brief, that'd be great. Thank you. Sorry.
No problem. My name is Teresa Zakaria. I work for the International Organization for Migration. I just wanted to highlight that being a migration-focused agency, that our focus in global health security is actually addressing the mobility dimension, because by understanding people's movement, we are better prepared to foresee how diseases can be transmitted across borders, and therefore then being able to put in place the necessary precautions to make sure that specific destination areas are well protected against the importation of diseases. Having said this, it is still very important to look at the protection dimension of migrants, because when people travel across international borders, they are most of the time rendered also more vulnerable because of their lack of access to healthcare due to cultural difference, language difference, and so on and so forth. We're working actively on responding to the Ebola crisis. What we have seen, for example, in the Sierra Leone Guinean border for Caria and Gambia, transmission is still ongoing, is very active, but there are lots of people's movement across this border simply for access to healthcare. Women and children from Guinea cross the border to Sierra Leone because healthcare is provided free of charge for women and children in Sierra Leone. And so at the moment, with Forcaria imposing a lockdown for 21 days, we also need to look at the specific implications to healthcare of women and children. Very quickly, just one last thing on a partnership with the private sector. In collecting information on mobility patterns in these Ebola-affected countries, we have also been very much relying on transportation agencies who provide us information on where people travel to and from, and also to help us spread messages on hygiene, on infectious disease prevention, and so on and so forth. Thank you.
Thank you for all of those comments, and I'm glad to see that that there is a lot of interest in the room to respond to what was said today by our panelists. I do want to ask Joanne, you had a few words that you wanted to say first.
No, thanks so much. As the Center for Global Health and Diplomacy, as Professor Sheila said, we have been the facilitator to the SADC Health Business Initiative. And also, we've been working on global health security for a while, and I feel like this conversation on the role of women and girls in the global health security is just beginning. So, we offer at the center to continue this dialogue with many of the partners around the room, and hopefully, we can have another forum so we start turning our discussion into action and helping you in terms of the U.S. government in Finland, as the chair, and helping you with the global health security agenda and how we get women and girls into that. So thank you.
Thanks, and I appreciate that offer, and we will keep you to that. All right, thank you. I want to thank all the panelists. I want to thank Joanne and for organizing this. I want to thank all of you for attending and for being patient this morning for the late start. And good